Good evening, everyone. It is my pleasure to welcome you tonight to tonight's event, appropriately entitled Connecticut Facts Q&A with the Experts. My name is Jeff Leake, a teacher in Cheshire and currently the president of the Connecticut Education Association. Leading tonight's webinar will be Senator Heather Summers, the ranking member of the Public Health Committee and a member of the Governor's COVID-19 Vaccine Advisory Committee. Joining the senator will be health experts who are here for a candid conversation about the COVID-19 vaccine implications for educators and school staff. We especially thank all of the members of the panel for their time and expertise this evening. Also here with me tonight is Mary Jordan, president of the Norwalk Federation of Teachers and a vice president of AFT Connecticut. And Mary and I will be working to moderate some portions of this evening's programs. I want to introduce Senator Summers first. Senator Heather Summers is a resident of Groton and represents the 18th State Senate District, which includes Griswold, Groton, North Stonington, Plainfield, Preston, Sterling, Stonington, and Voluntown. Senator Summers serves as the ranking member of the legislature's Public Health Committee and Transportation Committees. She is also a member of the Appropriations and Executive and Legislative Nominations Committee. Tonight, Senator Summers is here in her capacity as co-chair of Connecticut's Vaccine Advisory Group's Communications Subcommittee. She has been instrumental in organizing tonight's informational forum for the frontline educators and staff of Connecticut schools. Without any further ado, Senator Summers, I'm going to turn this webinar over to you. Thank you.
Thank you, Jeff, and good evening to everyone, and thank you for joining us here tonight. I am honored to be joined by panelists that have great depth and knowledge concerning this vaccine. A few of them are on the governor's task force concerning the COVID-19 vaccine. And I'm going to introduce them to you tonight. And I hope that you will feel comfortable asking any question that you would like tonight. We do have a list of questions that have come in previously that have been sent in, and we will go through those quickly first. And then we will open it up and Jeff will moderate as to any questions anybody who's on the webinar would like to ask. The goal here tonight is to make sure that you leave with your questions being answered by the experts. It's important to us that you understand everything about the vaccine, how it was developed, and any questions that you might have. And I'm looking forward tonight and spending it with you. So the first person that I would like to introduce tonight is Dr. Greg Shenghold. Dr. Shenghold is an emergency room physician. He's also the president of the Connecticut State Medical Society, and he can speak to whether he has actually received the vaccine or not. And we also have a special guest, which is Dr. Albert Coe, who is on the Scientific Review Committee. This committee is the committee, which is a subcommittee of the governor's COVID-19 Advisory Committee. And these folks are scientists and physicians that have gone through all of the safety and efficacy data that was submitted to the FDA on the two vaccines that have currently received their EUA or their emergency use authorization. So they basically were our little mini FDA in reviewing all the safety data. So he is our expert tonight who can speak to anything concerning, the genesis of the vaccine. And we typically start off by having him say a few words about the review process of the actual vaccines themselves to give everybody baseline information. And the last person is my co-chair on the Subcommunications Committee for the COVID-19 Task Force. His name is Dr. Joseph Quaranta. He is a primary care physician in Branford, Connecticut, with a plethora of experience, great person, great knowledge, has done a lot of these forums. So I welcome our panelists tonight and thank you for spending your evening with us. So if you'd like to get right into the questions, we can start. Many of you have submitted very similar questions tonight. So I thought I would start with one of them that seems to be the overwhelming question. And I'd love for Dr. Quaranta to jump in here. Everyone wants to know, when are teachers going to get vaccinated? That seems to be the #1 question. And the accompanying question to that is, why have teachers been pushed down? Why are they not being prioritized? So I would like to state first and unequivocally, teachers are a priority. They have not been pushed down. The way our system has worked here in the state of Connecticut is we have 3 subcommittees. We have the communication subcommittee, we have an allocation subcommittee, and we have the scientific review committee. The allocation committee, which is one that I do not sit on, but many of us work with them, has taken all of the considerations into play along with the recommendations from the CDC. After they debate, they basically put a report together. They hand it to the governor's office. At that point, the governor and the DPH commissioner take the recommendations, they evaluate it, they weigh it, and they are the ones making the final decisions on what the categories are to be able to hand out the vaccinations. The primary issue we have here, which is actually a good thing, is that the demand for our vaccines is way outstripping our supply. We want the demand to be high because we want everyone who wants to get vaccinated here in the state of Connecticut. So as far as teachers, they have always been frontline essential workers. They have been in category 1B, but because of the limited supply that we have received from the federal government, especially over the past few weeks, we have to prioritize those who are most vulnerable and affected by the disease. If you look at the data and the statistics, those who are 75 and older account for a very significant part of the deaths of COVID. 65 and older accounts for 89% of the deaths of COVID. And when you lower that number to 50, it's close to 98% of the deaths are 50 years and older. That's why we have started with 75 plus. We have now gone to 65 plus, and we will eventually open up another category, hopefully in the next 10 days. I want you to know that all of us are advocating for teachers because we understand that teachers are essential in getting our children back to school, which is desperately needed, and also our economy up and running. If you are a teacher who fits those age categories, you are currently right now eligible to get your vaccine. So I want you to know that you have not been pushed down and that it is very important to us. And quite frankly, Dr. Quaranta and I had a conversation with the person who's in charge of all of the allocation over Connecticut today, specifically because we were coming here. And he wanted us to make sure that you understood that you are a priority. Again, we are so limited because our supply is so small from the federal government. They are issuing us supply based on per capita. And we are hoping in the next 3 weeks that we should have additional supply, and we will be in a different position where we'll have so much vaccine, and we will be encouraging more and more people to try to take the vaccine. We're in a stage now where it's difficult because the first couple weeks of opening up a new category is always the most bumpy. We're hoping that that will be smoothed out in the next 2 weeks and we can open up an additional category. So I wanted to make sure everybody knew that. We understand you are important. This isn't anything that is punitive. This is simply basing the prioritization on the people that are most impacted by death by this virus. And Dr. Quaranta, if you would like to add to that quickly, that was quite a few of the questions tonight. So I wanted to try to get that out right out of the blocks. Dr. Quaranta?
Oh, you got it. There you go.
Apologies from me. First, sorry, I just want to add to the group here, and on behalf of all the panelists, which I'm sure they would all agree with, our thanks to all the educators who are with us here today. And as the father of 2 school-age children, I cannot tell you how much I appreciate all that each of you are doing to help us educate our children. And I think some of us on this panel can sympathize directly how challenging it is to do that in the time that we live and going to work every day in a setting where under these challenges. So first of all, I just wanted to say thank you so much. Your work is appreciated. It's value to us. And I can't tell you how important it has been to our children over the past year. And so just thank you so much. And I think, again, to echo Senator Summers' comments, the vaccine is coming to you. It's coming to you soon. You are in the highest priority group. The educators are in the first wave of frontline essential workers. The vaccine will be coming to you very shortly. I know the governor is working on final plans to announce for the next phase of the vaccine rollout. And the challenge is, as you know as well as I do, that we just don't have enough vaccine right now. What I can promise you as a healthcare provider is once we get the vaccine into our hands it will get into your arms as quickly as we possibly can. That I can promise you. Once the government gets us the vaccine, we will get it out to eligible candidates for the vaccine as quickly as possible. And so please just hang in there a little bit longer. The vaccine is coming.
Great. And just to add up to this or follow up to what Dr. Quaranta had said, one additional item that goes along with this, and then we're going to go to Dr. Ko, is people have asked, where am I going to get the vaccine? I'm an educator. How do I get it? We had this conversation today. When it is your turn, and you will know when it is your turn because we will be screaming it loudly from every media source that we can, along with good people like Jeff and Mary, making sure you know it's your time to be eligible. We are trying to set it up, and we've talked today with the governor's office and DPH. You will be able to get it at a variety of locations, whether it is through your employer, at the pharmacy, at a local health district, at a local hospital. We're going to make access for you to get this vaccine as easy as it possibly can be. We want to give you multiple ways to be able to get the vaccine. And that was something that we heard overwhelmingly today. So I want to switch, if we can, gears right now and send it over to Dr. Ko. Welcome, Dr. Ko. Thank you for being here. Dr. Ko is from Yale University. And if you could speak to us, Dr. Ko, and give us a little bit of background on the scientific review committee, what you looked at as far as the vaccine and its safety and efficacy data, that would be terrific.
Okay. Well, thank you very much, Senator Summers, and thank you very much, Mr. Leek, for the kind invitation. It's really quite a privilege and an honor to be speaking to really, some of the many of the frontline heroes in this story. And I just want to go back to emphasize what Dr. Quaranta said, in that if we think of what we went through in the last over the last year, there have been several acts of heroism, certainly by frontline healthcare workers, certainly by the vaccinators that have been stood up in the last couple of months. But surely, and I'm going back to kind of the when we were thinking about reopening Connecticut, to protect the safety and well-being of our state and our population, and most importantly our children. It's really been the job of the teachers. And what you've done through, since the beginning of the pandemic, but also certainly through the last the fall when we went through the resurgence. So just many thanks from all of us as citizens for your efforts. So going back to where we are right now in terms of the process, and this I would say has been one of the most rigorous processes. I've been an infectious disease physician, epidemiologists working throughout the world, mostly in South America, in the country of Brazil, working on vaccination programs for the last 30 years. And this is probably one of the most impressive scientific, but also public health achievements that has occurred over the last year. And that's getting safe and efficacious vaccines into the population within less than a year. At this point, we have 2 vaccines that went from early development, in the heydays, back a year ago, when the outbreak in Wuhan had happened. They went through manufacturers quickly developed these vaccines. They went into large-scale clinical trials that were conducted under the highest rigor. And then they went through the process starting in October, and this is the first vaccine to get emergency use authorization. That was the Pfizer vaccine, and then subsequently followed by the Moderna vaccine. And these were large trials done with 40, 50, 60,000 people with the highest scientific standards in the rigor in terms of the evaluation. And there are really 2 steps on this. The first step was 3 steps. The first step was the FDA to determine whether these were in fact effective vaccines, but also whether they were safe. The second step was done by the CDC, and particularly the American Committee for Immunization Practices, about giving its performance, its safety profile, its effectiveness, who should get the vaccine, and to maximize this public health achievement, given the fact that, as Dr. Summers says, and many things I'm going to say kind of ring true and resonate with what she had said in the preamble, but who should get the vaccine first and how we can maximize that public health benefit. Now that has come starting in December, and the vaccine advisory group was stood up in the middle of December or in the beginning of December. Quite quickly, for our scientific subcommittee, we received the entire packet of information from the FDA, but also from the CDC of the performance characteristics, all the work. And this is a committee of about roughly 10 people that poured over those documents. Many of them had to be done kind of in real time. So as it got FDA approval, we were meeting 2 days or 3 days afterwards to give our evaluation. And I think all of us were impressed. I can speak for the fellow members of the subcommittee. All of us were impressed by the rigor, by the design of the trials, the evidence that was produced. And that really led us to the large rollout of these vaccines, of the Moderna and the Pfizer vaccines. And I think there's also good news in the coming up. As Dr. Summers mentioned, we are in a situation where we have the capacity, particularly the state of Connecticut, to deliver more vaccines than we are receiving. To hopefully alleviate that, there are 2 vaccines that just finished clinical trials. One is the Novavax vaccine, and the other is a Johnson & Johnson vaccine, which is a real potential game changer if it passes FDA approval. And those documents have been submitted, and the FDA is going to be meeting next week. And that's a 1-dose vaccine, which will simplify the process. Our scientific subcommittee will meet 2 days after the FDA provides its recommendation next week about whether that vaccine, in fact, serves the purposes of the state of Connecticut and its citizens. So the good news in the future is that many of the bottlenecks that everyone has been working 24 hours, 7 days a week in launching this mass vaccine campaign, which is truly unprecedented. In our history of public health in the United States, we've never done a mass vaccine campaign as being accomplished at this moment. And more help is on the way with respect to new vaccines and filling the demand that we critically need, especially to the important segments and critical elements of a society such as teachers. So let me stop there. And that's just kind of the overview of where we started from, what we went through, particularly with the first lot of 2 vaccines, and now where we're going to be heading towards, at least in terms of the science driving these interventions.
Great. So we will get right into the questions. I don't believe that these are in any particular order. So I'm just going to start listing them out. And Dr. Quaranta, Dr. Schengold, Dr. Ko, please feel free. Anybody jump in at any time. So if you want to unmute yourselves so you can weigh in, that'd be great. I know Dr. Schengold, you're still muted, and Dr. Ko, you just went back on mute. So again, these are not in any particular order. I'm just going down the list. So one of the first questions we have is, if I didn't get the flu, is it safe for me to get a COVID shot? If I did not get the flu, can I get a COVID shot? Go ahead and answer, whoever would like to. I don't want to answer for everybody. Dr. Quaranta?
The answer to that is definitely yes. And whether you were asking if you didn't get the flu or you didn't get the flu vaccine, whether, I'm not sure which one it was.
The question was, if I didn't get the flu, is it safe to get the COVID shot?
Yes, absolutely. Whether you had the flu or not would have no bearing on your ability to get the COVID vaccine. So whether you didn't have the flu or you did have the flu, you should get the COVID vaccine.
What if you didn't have the flu shot?
You should still get the COVID vaccine. We are recommending 2 weeks generally between any other vaccinations and the COVID vaccine, although most people have finished their flu vaccination for the season.
Great. The next question, I guess we'll just go down the line here. How many severe reactions are we seeing from the COVID-19 vaccine? Dr. Ko, do you want to take that? You're on that committee that reviews all of the reactions, so to speak.
So let me just preface that we have a lot of information that came from large clinical trials where 40, 50, 60,000 people were vaccinated. And the risk of, in those populations of 40, 60,000 people, severe life-threatening adverse reactions were not identified to be associated with the vaccine. Now we're having much more information. At this point, we've immunized, at least given one dose to 12% of all Americans. We've delivered 72,000 doses of the vaccine. We have a lot of knowledge, gained a lot of knowledge about the very, very rare side effects that could occur. The one that is probably most worrisome in that we've heard in the news is anaphylaxis. This is the type of immediate reactions, allergic reactions that people get. Sometimes they get hypotension, swelling, difficulty breathing. And the experience has been really quite important. Of the tens of millions of people that have been vaccinated so far, there's been about 90 cases. So it's an extremely rare event. Those severe anaphylactic reactions that have occurred, and many of those are the large majority of those were all easily treated. With at the time of vaccination, they usually occur between 15 and 30 minutes after the administration of the vaccine, so they're readily addressed with good outcomes.
Right, and that is why when you do get vaccinated, you are watched for a period of 15 minutes. And if you are known to have allergic reactions, you're watched for 30 minutes. And they do have the availability of medications should that happen right then and there. That also slows down the vaccination process a little bit also. The next question we have, and I'm going to go through these because there are quite a few, is who is at risk to take the vaccine? What is the vaccine made up of? And how long does it last? 3 within 1 question. So whoever would like to take it, Dr. Quaranta, Dr. Shangold, please feel free to weigh in.
Well, I'm probably a little bit better on the last question because I've treated a few of the adverse reactions that did happen. And again, they were very mild, and the ones I saw didn't even need epinephrine, and they were just really treated with antihistamines. As far as the 3 questions you just answered, my understanding, and it's always good to have an ID doctor as a consult, but these are composed of mRNA, which is a genetic material that goes in and helps your body code for a protein, which then you're going to make antibodies too. What were the other portions of those questions there too?
Who is at risk to take the vaccine?
Again, the people I saw and the people I know that they're warning are people that have had previous serious allergies. And certainly when you've had the first dose of it, since there's 2 doses that are required, if you have had an adverse reaction, I believe you're at that same risk, even at more risk when you're getting the other ones. And then certainly you want to talk to your doctor about getting that second dose. But there is some ways to get that second dose and get pre-treated for the allergies, just expecting you to have an adverse reaction.
Great. Dr. Quaranta, do you want to weigh in on how long the immunization works for? You're muted. There you go.
I think that the correct answer to that is we don't know yet. So I think our hope is that the vaccine will provide an extended period of immunity. And the vaccines are new, though, and we haven't had the ability to follow patients who've received the vaccines out far enough to know what the tail end of the coverage is going to be. So I think the best answer is that's an ongoing question. Studies are ongoing to actually answer that question and to come up with the best advice about how long the current vaccination schedule will last. Will there need to be boosters in the future? And so that's actively ongoing now. And I think right now the best focus is get vaccinated now, because we do know that in the short and immediate term, the vaccine provides a significant benefit. And over time, we'll have better answers to what the next step will be.
And this isn't new to the COVID vaccine. There's many vaccines that we've had in the past that last a lifetime, and there's other ones that we do need every 5 or 10 years, like tetanus and pertussis. So this isn't unique to our COVID situation.
Okay, thank you. The next question. I have a history of anaphylaxis. I also have asthma. and on a steroid inhaler. Should I get the vaccine? Dr. Coe, Dr. Quaranta, Dr. Shangold?
Okay, so I think the answer is very much has been dealt with by Dr. Shangold. At this point, the indications with people, irrespective of their history of anaphylaxis, should get the vaccine. But that's why, as you said, Senator Summers, that we do want to follow people immediately after they've gotten vaccinated, or observe them for 15 minutes, and if they start developing symptoms, or for a more prolonged period of 30 minutes. The people who are, so in that one specific case, there's not a specific contraindication. It's always good, as Dr. Shangold said, is to always talk to your physician or a primary healthcare provider, because they're the ones who know you best, and then they can help you with that risk assessment. But again, this vaccine with people who have, anaphylaxis is not uncommon. My daughter and my wife have have had anaphylaxis, carry an EpiJet with because of peanut allergies, because of shellfish allergies. Anaphylaxis is not uncommon, and so that in of itself shouldn't be a contraindication for receiving this vaccine. This vaccine, as Dr. Shangold said, is made by mRNA, which is fairly inert. We don't really have anaphylactic reactions to that. The one that, the pieces of that vaccine, which is really kind of these little particles, which these RNA are buried in to help deliver, those may, potentially be responsible for these very, very rare kind of reactions that occur.
And I guess I would add, since there's going to be multiple centers that can give the vaccines, if you really have very severe allergies, you might want to do it more in a hospital setting where the distribution center is in the hospital than in a pharmacy or in a mass vaccination center. And that way, if there was a bad reaction, you're closer to where you need to be for care.
Okay, the next question is, if education and the well-being of students is truly important, then why are we not vaccinating teachers before prisoners? I would like to say that the prisoners that are being vaccinated are in the 75-year-old and plus category, now in the 65-year-old and plus category. So they are not prioritized over teachers. They are getting vaccines based on the age and the eligibility based on the age. The next question is the vaccine safe for people who have had kidney or other organ transplants? Dr. Quaranta?
Yes, it is.
Okay, yes, it is. The next question.
And Senator, I just would say to that too, though, that the disease is more serious in these immunocompromised patients. So they should have even more reason to get the vaccine, because if they do get the disease, there's chance of more serious complications.
Absolutely. So how much immunity, if any, do you have between the first and the second dose of the shot? And how long do you have to wait until you have full immunity? In addition, do you have to get the same manufacturer each time you get the shot? Whoever would like to take that, go right ahead.
I guess I can take that. That came up multiple times when we were reviewing, the process here at the, as part of this, science subcommittee, the vaccine advisory group, and it's certainly on a lot of our minds with this shortage. So the first question was that if you get the first shot, how long does that? Well, how much does that protect you? We don't know specifically for the Moderna vaccine or the Pfizer vaccine, the two vaccines which are currently approved and being widely used here. We suspect that the protection is probably going to be fairly high, around 50%. It's not going to be the 95%, but it's about 50%. And this is from new data that's coming out of Israel, which has done a large vaccination campaign, has immunized roughly about 30 or 40% of its population. So it looks like, you're going to get some protection, but that's why the current recommendations is to get that second dose. So the second part of that question you had is, So what happens? Do you need to get it exactly at 4 weeks, or can you get it, a little bit later, especially when we're going to have a little bit, some potential snafus in the, in scheduling and in appointments. So again, we do want people to get that vaccine as soon as possible. We know that after 2 weeks after that second vaccine, protection is over 95% from getting illness or severe complications from COVID. So what happens if that gets a little bit extended? Well, certainly, we want to get people as covered as quickly as possible, but actually extending it doesn't affect the overall effectiveness you will get after the second vaccine. So if you're delayed 5 weeks or 6 weeks, and probably even longer, it's not going to affect the overall effectiveness once you get the second dose. But again, we want to get people vaccinated and get their second doses on schedule as close as possible.
Great, thank you for that answer. The next question is, does the vaccine impact fertility? Dr. Quaranta, I know you've been asked this many times. Do you want to start?
Yeah, that's a great question, and it's an important question. So there is no evidence at all in the studies that have been done, the trials have been done, that either the Moderna or the Pfizer vaccine impacts fertility at all. The rates of pregnancy, being able to get pregnant in those trials were the same. And so there really is no scientific foundation to the question of the vaccines having any effect on your ability to get pregnant.
And a follow-up to that, the next question, which goes right along with this, if this vaccine is so safe, then why is it not indicated for pregnant women or children?
That's an important question. I want to just make some general comments. The first thing I think is important to understand is that anytime we recommend any therapeutic in pregnancy, we treat that fundamentally differently than we do in other populations for obvious reasons. So across the board, the approach we take to recommending anything in pregnancy, and for those who can remember, even if it's something as simple as a routine medication or something as simple as a Tylenol, we take extra precaution and extra care in pregnant women for obvious and important reasons. So that I think is one of the reasons that you notice a difference when we talk about our recommendations when women who are pregnant. And so then I want to say a couple of things. First of all, we do know what are the facts around this. One of the facts that's very important that we do know are pregnant women are at increased risk for more severe complications from COVID. So that we do know. The trials and the studies were not designed specifically, though, because of the timing of the trials and the stage we are at in the development of the vaccine, to assess the safety specifically in pregnant women. And so because of that, we're left with having to make recommendations without complete evidence about what to do for women who are pregnant, but I think with the strong sense of some suggestions that we can make. And that's where we come down to the final answer, that every person has to really think about their own personal situation, has to have an honest and open conversation with their physician or their midwife about what's best for them. What are some of the things that might impact your decision about that? What is your own personal exposure to COVID? What are your other medical conditions that might increase your risk of a poor outcome if you contracted COVID? What are your ability to quarantine and work from home or not during your pregnancy? And what are your other personal family characteristics that might come into play in terms of other members of your family that might be at risk for exposure? The other thing I also want to say is that we have a long history of administering vaccines in pregnant women and doing it safely and with positive outcomes. And so I think that's another factor to understand, that although we don't have all the data yet on the COVID vaccine, we have a long history of experience with vaccines in pregnant women and have a good understanding of which type of vaccines can be administered safely if that's the decision that the patient wants to make. So I don't know if any other panelists want to add to that, if this is a more complicated answer and question than most of our others.
I don't know, Dr. Koh, would you like to touch on the children question as part of the trials?
Yeah, I think the children one, I'll come back in a second. So again, this is, I'm just going to back up everything that Dr. Quaranta said. And so at this point, the two vaccines, there are no contraindications. The FDA did not place any contraindications to getting vaccines even though, as Dr. Quaranta said, pregnant women were not enrolled in this study. And I think this is kind of the key issue to kind of drill down on. And I think there were really important points. The first one that Dr. Quaranta said is that pregnant women have more severe outcomes. And there's also some evidence that there's more severe fetal outcomes associated with COVID. So certainly there's a risk, an increased risk. The second is that knowing what we know about the biology of this vaccine, this is not a live virus or attenuated virus, but this is an inert mRNA or genetic-based vaccine, that this really doesn't have any biologically plausible ways to really cause harm during pregnancy, and as well women who are breastfeeding. So the position of the FDA, and I think, one of the things that we also have to think about is the equity issue or the social justice issue. Many times pregnant women are, excluded from initial stages of the trial, as what happened during the COVID, and that there's really the ethical issue that women should have the right to make their decisions, and especially in concert with their primary healthcare provider about that kind of risk benefit, because of that risk benefit. So cutting to the chase, I think, as Dr. Quaranta said, women are eligible to take the vaccine. Pregnant women are eligible to take the vaccine. They are at higher risk, and that it's important to emphasize that these decisions are always best done with their obstetrician or their primary healthcare provider who knows them well about making that decision whether they get vaccinated now or potentially delaying that. So that's the part, and they're kind of important parts, and just wanted to make sure to emphasize many of the issues that essential issues that Dr. Quaranta said. Now with children, that's the part is different. So children were not included in the trials from Moderna and Pfizer, and they were, actually in the Pfizer trial, they included people 16 years and above, and in Moderna, 18 years and above. And the risk from the large amount of evidence that we've accrued, not only here in the United States, but around the world, is that the risk for children is much lower and much different from adults, and certainly much lower than what occurs during pregnancy. So the issue, the judgment, and this was thoroughly vetted, and it was a source of a prolonged discussion for our vaccine subcommittee, was that until there is evidence that's going to be accrued on the benefit in children, the best part is to defer that until such evidence is occurred. Now, right in October, after the Moderna and Pfizer, submitted their EUA applications, they immediately started trials on children, from 12 to 16 or 10 to 16 years of age. And so we should have this information about whether it's safe to give to children coming in the next 3-4 months. And that actually goes into sync when we think about the prioritization that we really, as Senator Summers said initially, we want to vaccinate the people at the highest risk, and those are the people, the elderly, and in specific epidemiological settings that place people at risk. Once we get down, and we're thinking about whether it's May, June, July, vaccinating large parts, we should have that, large segments of our population, including children. We should have the evidence, really firm evidence by then about the effectiveness and the safety of that in that age group.
Great. So thank you for that answer. The next question is, based on the data, is COVID spreading in schools, or are positive cases coming from contact outside of schools? I'm not sure who would like to take that. I know that you all have experience with that, so feel free to just jump in. Dr. Quaranta, Dr. Shangold? No one wants to take this question.
So let me take that, I guess, because I'm in.
I can tell you that we have some information that a lot of the transmission is coming from outside school sports that are being brought into the school. But that the schools in general, with all the precautions that you are taking and your attempt to social distance, I know it's really tough to do the 6 feet, but masking and cleaning, that the schools tend to be one of the safest places to be. So would anybody like to add to that?
Yeah, so Senator Summers, our group here at Yale, in support of the state and particularly Department of Public Health, are helping work through some of those issues. And let me just kind of go back to some of the evidence. But first, before that, going to the caveats. So many times when you're in the middle of a surge, it's very difficult to understand where people got infected or exposed, especially when we have high levels of transmission. And it's kind of the chicken and the egg situation. You know, is it really coming from the home or from the outside of the school environment, or is the transmission occurring in the school? But let me kind of cite some of the evidence. So we have a lot of evidence here in the United States, as well as across the world, that there's limited evidence showing that schools are at risk or high risk. There were some problems, for example, early on the epidemic in Israel, where they had highly crowded schools. There was very little risk mitigation, and there were outbreaks large outbreaks in high school students, and also in France. But after that, once risk mitigation, this is the cohorting of breaking up in pods into students, the distancing, the use of face masks. Here, at least in our state, there have been very few school-associated or classroom-associated outbreaks. Second of all, there's no evidence that's showing, at least firm smoking gun evidence showing that schools, that as a congregate setting is leading to increased transmission, either in the school or spillovering into the community. And the third part is, and I think that this is all a testament to kind of the interventions that Connecticut, but many states and many countries have done in terms of decreasing the risk through, hygiene, through face masks, through social cohorting, or breaking up students into pods. So, I think we have pretty good evidence. Well, there's certainly a lack of evidence pointing to schools as a source of increased transmission. And when there are outbreaks, and we've had small clusters, as you said, Senator Summers, many of them have been happening either with sporting events associated with schools or outside of school activities.
So I would just like to add, it's also a testament to the fact how hard our teachers are working in implementing these risk mitigation protocols that I know are so difficult to maintain and have really turned your life upside down. So again, we salute you for being, part of the solution in this very, very difficult time. And you have done a wonderful job at keeping all the children as safe as they possibly can be. So we hail you. We really appreciate all that work, and your work does not go unseen or on deaf ears. We understand it intimately, and we are very, very thankful for all the work that you guys have been doing and continue to do until we can get enough vaccine to get you vaccinated. I will say, could you speak to the fact that even once you're vaccinated, you still have to wear a mask and continue to socially distance? That seems to be a question that comes up repeatedly. Could one of you like to explain why that's so important? Dr. Quaranta, Dr. Shanhold?
I think it goes back to some of our other questions, which is we don't know some of the things that a lot of the science is being developed as we develop these policies. But it's possible that you might not get the disease, but you still might have the coronavirus and be able to spread it. So even though you won't get the disease by being vaccinated, it's possible you can pass it along to somebody else that hasn't been vaccinated that is at higher risk. And so until that's clearly vetted out, that's the reason. I think there's been if you go back and you look at other viruses through time, there's a few cases of people that don't have disease, but then end up spreading it through it. And I think there's some analogies that can be looked at with chickenpox and typhoid that are, that people can look at. So until we get more and more information, we want to have the most cautious outlook.
Great, thank you for that. There's a few questions in here that are very similar, so I'm going to try to lump them all together. And this has to do with if I have tested positive for COVID or if I've had COVID, how long do I need to wait before I can get my vaccine? Is it 90 days? Is it 30 days? Dr. Quaranta, Dr. Ko, anybody?
So, Dr. Quaranta, would you like to answer that, or?
Well, you go ahead, you started, that's fine.
Good, good. Yeah, okay, so I think the rule is that if you've been exposed, and infected with that, there needs to be that 10 days since you've been infected, that you're not eligible for the vaccine, that you should wait and defer during the illness of the vaccine. And that's more a safeguard. We don't really know, let's say, if getting a vaccine right on top of getting COVID will actually make you worse or better, but it's more kind of a safeguard. So people are eligible if you had COVID 10 days after your the onset of your illness or your first positive test. So the question is that, well, do you really need to get it immediately then? And I think what we know from at least there's all the epidemiological studies and clinical research that's been done is that after you've gotten COVID, you likely have immunity. We don't know for how long. It's very much like the vaccines, but there is information from these long-term studies that it's at least 3 months and perhaps longer. So that's why there's a little clause in that, is that, okay, you're eligible to get the vaccine 10 days after you've gotten the illness, but you can defer that, in talking to your primary healthcare provider, you could defer that up to 90 days because you're probably going to be immune and protected against getting another COVID infection, at least for that time, if not longer. So that's generally where the recommendations come in guiding people who've been infected with COVID. Now, let me just say that there have been, the majority of infections due to COVID, people don't know that they've even been exposed. So we're immunizing a lot of people, and that happened certainly during the clinical trials, who were exposed to COVID, didn't know they had COVID, and got the vaccine and continue to have protection. So there's nothing about getting the vaccine that would interrupt the protection that you would have after getting a natural infection.
Senator, I just had a couple of points that I just point out. Dr. Cole mentioned the 10-day minimum time period for getting vaccinated. Some healthcare organizations, as part of the scheduling process, are going to ask you to wait a little bit longer. So you don't be surprised if you see an organization through their scheduling system say, please wait 4 weeks for your vaccination. I'll answer a second question. What if you get COVID after you get the first vaccine, but before you get the second? That hopefully won't happen when you start getting vaccinated. And then the recommendation is to complete your vaccination cycle as close to the scheduled time as possible once you've been cleared through the COVID quarantine process. So you should still get vaccinated if under the unfortunate circumstance you get it after the first vaccine. And it will happen once we start vaccinating people. And the final caveat is that for those of you who may have been treated with monoclonal antibodies, and it's a small number of people, but it's getting larger. If you've been treated with monoclonal antibodies as part of your COVID treatment, then you need to wait a longer period of time for you to get your vaccination. The current recommendation is 90 days. So there's a few specific points on that. Key question is, if you have a question about when to get vaccinated, talk to your physician or your healthcare provider. Everybody's circumstances is a little bit different. They can walk you through this.
Right. And another key takeaway is if you have had COVID, you should still get the vaccine. So the next question is about the mutations and how concerned should we be about the virus mutations? Everyone seems to be acting like the worst is over. Is it, and will these vaccines be effective against the mutations? Dr. Ko, Dr. Quaranta, Dr. Shangold, who would like to take that one? Dr. Ko, why don't we pick on you?
All right, good. So a couple of things. One is that we're certainly worried about these new variants. The state is certainly very concerned. They're setting up genomic surveillance. They're keeping close monitoring on that situation. The reason why is because And this, I think the first point is that it's going to take us a while. We're going to have to vaccinate a large number, a segment or swath of our population to see those population level benefits. Those may not kick in until 2, 3, 4 months from now. When we start vaccinating not only 30, 40, but we may have to get up to 50 or 60% or more of our population to see those population benefits. So these variants, particularly the one from the United Kingdom, are already here, and they're here in our state. And so we're concerned about them because of the transmission and the possibility of a third surge, created by those before the benefits, the population level benefits of the vaccine kick in. So that's the first thing that we're worried about. And that really, we have to double down, not only in ramping up the vaccines, but we have to double down in terms of, the things that we know work, the ABCs, the face masks, the social distancing, the limiting gathering size, and preventing these super spreading events that fuel COVID transmission. So now the question comes, what do we know about these mutants escaping the effects of the vaccine, and also not only escaping the effects of the vaccine, but the immunity that a first infection can give. So can people get reinfected? So it seems, I think the good news is that at least from a lot of, and this is all in evolution, we have to be kind of humble about what we know and what we don't know. But the body of evidence that's now coming out about the variant that we're most concerned about, because it's here in Connecticut, which is the UK variant, the body of evidence is indicating or suggesting at a first pass that actually the vaccines, whether it's the Pfizer vaccine, the Moderna vaccine, but also the vaccines used in Europe, like the AstraZeneca vaccines, probably are going to be effective against that. I think the best case of that is Israel has a whopping, epidemic of the UK variant at this point. 70% of their cases are due to the UK variant, but they're seeing, cases, overall case numbers drop with the rollout of their vaccination. So that's the good news. I think what we're worried about is what's happening in Brazil and what's happening in South Africa. And those variants are carrying mutations that may potentially affect the effectiveness of the vaccines. And we're I think we're keeping our eyes on what information. I'm working actually with the group. I worked the last 30 years in Brazil and working with the group to evaluate, how those vaccines are working against these new variants. And it's really too early to tell. There are some, worrisome information that's come out of South Africa that maybe the effectiveness of these vaccines may be attenuated or reduced. And so we're going to learn a lot in the next month about that. But that's what's in the potential forefront for us.
Great. Well, we have quite a few more questions, but I think we're going to take a different turn here, and we're going to turn it over to Jeff and let him go ahead and talk to those who are watching so they can ask their questions. Many of them may be some of the same ones that we had here. So thank you to everyone who sent in your questions in advance. So Jeff, if you would like to take it away and go ahead and let people have an opportunity to ask the questions who are on, that would be great. Oh.
There we go. So my intention is to put a question in, and then Mary, why don't you pick one out from the questions as well? The question that I'm going to ask you is this. The J&J vaccine doesn't seem to have the same level of efficacy as the mRNA vaccines. Can any of you comment on that? And is there any sort of a trial going on with a second dose of the J&J and whether that will be as effective or almost as effective as the other two? Anyone want to take that one? I don't know, Dr. Cole. It looks like it's you.
Okay. Let me see. So let's say, so the documents for the J&J and the data, and these were extensive trials done in South Africa, done in the United States and the United Kingdom. They've been submitted to the FDA. So we're waiting to look at, not just what's come out in the press briefs, but that the granular data. These are huge packets. These are like large binders, and we need to go through that. But at least from the press release, you're right, Mr. Leek, that the J&J the proportion of the percent reduction or the protection afforded by that may be lower than what we see in the Moderna, in the Moderna and the Pfizer vaccine. On the other hand, we have to think about this is a 1-dose vaccine rather than a 2-dose vaccine. And there are what we call, when we think about the importance of vaccines, there's a individual level effect. So for example, if I get vaccinated, how much does that protect me? But myself getting vaccinated is going to protect Senator Summers. It's going to protect Dr. Quaranta. It's going to protect Dr. Shangle. And those are the indirect effects, what we call that herd immunity. So that 1 dose, even though it may not give me as much protection as the next person, as the next vaccine, like the Moderna Pfizer vaccine, the ability to get that out quickly to large swaths of our population is going to give us that, what we call that population level benefit quicker and sooner. And that's our aspiration and desire with the Johnson & Johnson vaccine, if the regulatory approval, all the due diligence and the due process is done. Now, given that J&J is starting trials where they're giving a booster, they're also starting trials where they're giving a booster with a vaccine that hopefully is going to be effective against some of these variants that are popping up. And a lot of these drug companies are starting the discussion about, and I think which was an earlier conversation, that let's say if I get the J&J, can I get the Pfizer vaccine afterwards, or can I get the AstraZeneca, or can I get another vaccine? And will it work? So those are all on the checklist for all the researchers for this year to come up with those type of answers.
I might also add just the point, the timing of the trials for Moderna and Pfizer and the later vaccines are different. And it's a different world now with variants than it was several months ago. So just to be careful, these trials were not designed to be compared to each other. And it's not always fair to look at one study versus another study. And there may be some effect of the emerging variants that the Johnson & Johnson trial has picked up that was not present at the time that the initial Moderna and Pfizer vaccines were done. So I think I would just express some caution with worrying too much about, and particularly until we see the final data, about making a judgment about whether one vaccine is more effective than the other going forward.
Thank you. That's helpful. Jeff, did that answer your question? Can I jump in here? Okay. I think I'll take a couple of questions and sort of lump them together that are very practical minded. So some part of this has already been answered by you, Senator Summers, but I'm going to throw it out there. I think people logged in just a few minutes late. For school employees who are ready to be vaccinated, whose name has come up, are they required to go through VAMS? Can they get this through other places? And then is there going to be another group of 50-year-olds that will follow 65-year-olds? I think some people heard the comments about the mortality rates and the impact on 50-year-olds and are thinking that that's another group. I hadn't heard about that. I'd love to hear that confirmed one way or the other. Is there a group that includes 50-year-olds that will come before teachers? And then when school employees finally get their shots, how do we prevent or reduce the symptoms that come with the second shot?
Great, those are all great questions. So as far as the 50 and above, that was just to give you some data. As far as it's my understanding that right now we're at 75 plus, 65 plus, which accounts for 89% of the deaths from COVID. And we were just using that as an example. If you dropped it to 50, that would account for 99% of the deaths and a lot of the comorbidities. It is not any intention, I believe, that they're going to go to 50 by at all. But doing it by age, it simplifies it. You're not, pitting one essential worker versus another. But right now, the focus has been 75 and above, 65 and above. That's where we are. Healthcare workers, people that have direct contact with folks who are COVID, certain congregate settings where people cannot self-isolate, usually that are elderly within those age categories. And the next part of that was, I already forgot your first part of your question. I'm sorry.
If you get that second shot.
Yes.
I know for you, it would be where can you get that?
Oh, right.
Get your shot.
So-
Can you get it anywhere? Are you required to go through your employer?
No, you would not be required to go through your employer. The tricky part will be if your employer has loaded you into the VAM system, then you could choose to continue through the VAM system, which will give you opportunities to get the vaccine. You can call and make your appointment at a health clinic, a health district. Some of the hospitals are taking VAM. We're also going to be setting up some drive-through clinics where you'd be able to drive in your car, not even get out of your car to get the vaccine. The one thing is, once you're in the VAM system, you can't then switch over to, let's say, Hartford Healthcare because they have a different system, or Yale because they have a different system. So if you have not signed up through VAMS, you will have access to try to get it at a hospital like Hartford Healthcare or Yale Healthcare System. You can call health districts directly, but to get it at a pharmacy, a drive-in clinic, those types of areas to get the vaccine, you will go through the VAM system. So you can do it through your employer, or if your employer has not loaded all the names in the system, then you can do it yourself. That's what the 75-year-olds are doing. You can go online when you're eligible, you get a number in VAMS, you sign up and it assigns you an appointment time. It'll be much easier by the time that you guys are eligible, because we're hoping in the next few weeks, we will have much more vaccine to be able to spread across the state of Connecticut. And in addition, if we have these other vaccines that get their EUA approval through the FDA, we will have an ability to have even more types of vaccines. One of the difficulty of this vaccine is because of the storage conditions. So you can't have it at a doctor's office because of the deep freeze that is required in the Pfizer vaccine, and the Moderna vaccine also has to be refrigerated. We are doing everything we can to make sure that when teachers and teaching staff are eligible, you have access to as many different possibilities to get the vaccine as we can possibly have for you. I
Thank you.
hope that answered your question.
I think that covered a number of them that are up there in the.
And the
in
last
chat.
part of the question was,
Reducing symptoms from the second shot for the reactions. We have seen a number of those.
Mhm.
So any advice
I'm going to
about
turn that over to the expert clinicians, but I do know that if you have a reaction on the first shot, you tend to have another reaction on the second shot. I'd love for them to speak because most of them have actually had the shot themselves, so they could talk about it directly. So go ahead, Dr. Quaranta, we'll start with you.
Yeah, so I think, so first off, I mean, to be clear, when we're talking about a reaction, we're talking about things that many of you are familiar with. It's not a what we call an adverse reaction or a complication from the vaccine. It's an expected and a normal process when somebody receives a vaccination. We're all educators, so you're all educated, so you understand, when children get that vaccine, the next day they have some mild symptoms. So these are things that we're talking about. So completely expected and not a sign of something going wrong with the vaccine. When the trials were looked at, the rates of side effects were very low in both vaccines. What we're clearly seeing, though, as we do a larger rollout, is that the first dose is tolerated extremely well, with mostly minimal side effects for most people, although some people do have more of a reaction with the first dose. The second dose does clearly seem to have a higher incidence of a vaccine reaction after the dose, anywhere from the first day to the second day. A couple things to understand about that, though. It doesn't have any long-lasting effect. It is short-lived and self-limited and goes away on its own. It presents with things like some fatigue, perhaps some muscle aches, a headache, and some low-grade fever. All things that are not complicated by anything more than that. And they, in almost every single case, pass within 24 hours or by the second day of the vaccine. In terms of things to do to mitigate those symptoms, there are some things you can try. Obviously, rest, hydration. There's some thought about avoiding anti-inflammatories during the vaccine process because of some potential theoretical effect on the vaccine efficacy. So we're not recommending that overly. Tylenol is safe and effective to use. But in many respects, just some good old-fashioned time, rest, and give it a little bit of a time to pass. What I'll mention particularly for this group, and we went through this in the healthcare field, is is there any rationale to try to stagger the vaccine schedule for educators and teachers? And there may be some thought to doing that. If I'm not sure you want to give every teacher in one school their second dose on the same day on a Monday, for example. And we went through this, and so there may be some rationale for individual schools to think about staggering, and so that may make some sense so that people are not getting their second dose all on the same day. I'd be curious if any other docs have any other thoughts on mitigating side effects or other things.
I think you covered it pretty well there, but the scheduling piece is definitely true. You know, in the emergency department, we just didn't want, you know, a bunch of people to be out on the same day when it's something essential that has to be staffed, and schools definitely fall into that category. And so there might be enough people to have that fever and that muscle ache and just don't feel well enough to do their job, that not to have them all on the same day.
Ideally, if you were going to do a school-based clinic for a vaccine, I would suggest do it on a Friday.
Yeah.
Because that would probably be more than enough time. Although then that you might have a different opinion about that because of the weekend. But at least from the work standpoint, we would have no issue for work outage over the weekend. We'll be back by Monday.
Thank you.
So I'll just add that. So I got the vaccine. I think you know, I think as Dr. Quaranta said, the second, you know, like what we're seeing throughout, the second dose is having associated with more effects. You know, the headache, the nausea, the chills and the fevers. For myself, I got it one day and I felt really pretty good, and then the next day for about 12 hours. I was kind of like laid up a little bit, and it's quite varied. Some people go through without any, any pain or any, fevers or chills. Other people, may have to, be sick enough to get off of work. I think the one thing that, we are kind of, this is not a recommendation, but a lot of this comes from the pediatric field, is that what we don't do is we're not generally recommending, and this is not a CDC regulation, but we're not recommending pre-medicating. So for example, taking Tylenol or taking aspirin or non-steroidal anti-inflammatory before the vaccine. I know people have been talking about that, and a lot of this is on Twitter and the social media about doing so. I think in general, I think the consensus is to avoid that, because we want people, we want the vaccine to work, and we want it to induce a good immune response, and we don't really know what these agents would do to attenuate that, or perhaps not.
Thank you. I think there's a question here that's sort of a clarifying question, and maybe I don't know who wants to take it, but if a school district has already got their folks into the VAM system, is that meaning that let's say a person is there, but they're 65, can they not go to Hartford Healthcare? Are they automatically excluded because they're already in VAMs? Is there?
Yeah, so I can speak to the current status is, so let me, because I do a lot of 65-year-olds. So you can certainly register in VAMs and schedule your vaccine through one of the VAMs facilities. You could also independently go to Hartford Healthcare, Yale New Haven Health, or St. Francis and directly register through there. So you're not limited. And I think, we met with I'm only hesitating because it's still not finalized, the plan is, but I think the expectation is that for teachers and for other essential frontline workers, to offer them the options to take advantage of the breadth of clinical sites to get their vaccines, and whether that's through a VAMS process facilitated by their employer or by them directly, perhaps through a clinic that might be managed by a local health department, or if they so choose to go to Hartford Healthcare, which may be their provider, and register through them. And so I think that's going to be the process. But yeah, so individuals can kind of register and manage through different systems, and many people do that as they try to navigate their way through the scheduling system.
I will just tell you that some of the difficulty we've run into is once you're in the VAM system and you have your first shot, then you try to get a second shot quicker, and you want to go into the Hartford Healthcare shot. It's just very difficult, and they don't want to do that because one hospital has just Moderna, another one has just Pfizer. They want to make sure you're getting the same vaccine the first time as you do the second time. So you can move around. It's just not as easy as it should be. We're hoping that in the next couple weeks we'll have all those kinks worked out. There also is, I failed to mention, there will be possibility of doing like teacher clinics through the health districts, so that health districts will set aside time where teachers can go locally to their health district and be able to get their vaccinations that way. But it is a complicated system because some people use VAMS, some people, Hartford Healthcare and Yale have a different system, and some of the health districts have a different system. The big thing is if you get into VAMS and you make an appointment and you end up going someplace else, we really need you to cancel that VAMS appointment so it opens up for someone else. And hopefully it'll be much more clear by there, but our intention is to be able to basically have such flexibility that if you are a teacher or somebody working in the school system, you should be able to get a vaccine wherever it is most convenient for you. And we want to give you as much opportunity as we possibly can.
Thank you for that clarification. Mary?
Thank you. There are a couple of questions in the chat about the amount of vaccines that have been distributed but not administered. I wonder if somebody can explain or describe. It's for people who are so eager to get we have this sense of urgency for the vaccines. We're waiting. We're hearing that it's rare, and there's not 100% administration of the vaccines. Dr. Quaranta?
You know, I
Yes,
saw
I'm
that.
happy
I
to
went and
follow up
looked
with
up I looked up the data. I saw that. So I wanted to answer that. So a couple things I want to comment on. First of all, the data that's released, we're trying to be as open and as transparent about everything. So yes, that is the most accurate data that we have. But there is a lag between when the vaccine is delivered and when the vaccine is administered. And the gap between what you're seeing, the 900 and some thousand that have been delivered to Connecticut and have been administered, shows that. And so why is that? One of the issues is that the experience in Connecticut has been fundamentally different in other states. And so what we're trying to do is we're trying to schedule people for vaccines that we know we have in hand to avoid long lines, to avoid people showing up at vaccine clinics when there are no vaccines. And when you look across Connecticut's experience, that has been the case. People aren't waiting for line 4 hours for a vaccine and then being turned away. People aren't having their appointments canceled because there isn't enough vaccine. So what we're seeing is that the clinics and the hospitals, they're scheduling their appointments for the current week based upon the vaccine supply that is then in the state and allocated to them. If you could look at the vaccine data at the end of the week, you'd see us catching up to the supply that was given out the week before. And so I know it's misleading to look at that discrepancy, but it's an anomaly due to the delivery of the vaccine comes in first, and then we're scheduling for the coming week for those vaccines that are coming in so that we have an orderly process.
Yes, and if I can just add to that, for example, if you go to a health district, in my health district, they will not schedule their appointments until Monday when they know exactly what their allocation is for that week. What they don't want is what we see in Florida and other states with these long lines where people wait for hours and they can't get a vaccine. So that data is just not caught up yet. I can tell you we have had one vial that I know of that has been wasted when a doctor, remember that he unexpectedly knocked one over by mistake. That's the only one that we have reported. Many of our clinicians that are giving out vaccines or clinical locations along with our health districts, they actually have a system with a wait list. So if somebody doesn't show up for a vaccine, they will start to call the list. Because these are so sensitive to temperature and thawing, they will not let one system go to waste. So there are times when people have come back the next morning because they don't want to open the packet of 5 to waste one if they can't get through all of them. So I can tell you we have a waste mitigation process and SOP with all the folks that are vaccinators. And these vaccines are treated like the true gems that they are. So don't let the data mislead you, because Connecticut is one of the top 3 states in getting the vaccine in people's arms and is doing a terrific job with the vaccines that we have.
And I also want to point out, there is a lot more capacity in the vaccine administration system. So it's not as if even giving out the number of vaccines that we're giving out now, that we're anywhere near maxed out in our vaccine capability. So when our vaccine supply increases, our ability to administer those vaccines is going to increase. And so that's the important point to understand, is as vaccine increases, the supply will increase. And as the state tells the provider groups, we have more vaccine for you next week, we add more vaccine slots, we add more vaccine clinics, and that vaccine is being used right away.
Thank you. Jeff? Jeff, I think you're muted.
Yes, I am. I keep doing that. If you have an allergy to penicillin, should you be worried about taking the vaccine? According to this person, that she was told that over the weekend.
No, she should not. No, again, the only allergies of concern are to the vaccine, to some of the substances in the vaccine, and penicillin is fine. There are also a number of questions in the chat about various questions about medical conditions and contraindication. There are currently no medical conditions we know that impose any contraindications to the vaccine. I think as Dr. Shanghold said previously, most of the time medical conditions make you more at need for the vaccine. And so somebody mentioned Meniere's disease and other things there. There's no evidence that there's any contraindication to those conditions.
Mary, maybe one more question and then just an opportunity for our panelists to say their last words and thank them again.
Sure. Actually, I think there's a really interesting question that's very science-y. So I'm trying to find that one about trials. If we had trials and now we're vaccinating the control group, did that one? That seems like it disappeared. Do you have a concern with that? So we had those initial vaccine trials. I can't read the question because I can't find it, but we went ahead and vaccinated the control group, and now we won't be able to follow that unvaccinated control group in a longitudinal way. If there's any response to that, I think that's an interesting question.
Dr. Ko, that would be a question for you.
Yeah, and so this is okay. So going back when the first success stories with the Moderna and the Pfizer vaccine, this question came up, and it's an ethical question, bioethical question about going back to not doing any harm or doing research that would potentially be associated with preventing the opportunity. And it's what we call the word we call is equipoise. So I think in this, of course, was something, and I'm on some of the WHO committees, that are specifically looking at this kind of predicament. So once you have a good vaccine, a vaccine that is effective, immediately it creates a bar, that for the other vaccines to be compared with, and in the fact of leaving a control group that's not vaccinated, the ethics around that. And so I think this is all an evolution. And I think what's also kind of complicated the whole system is this issue of variants, and everybody's had to redesign their trials in the last month, just because of what's happened, or last month and a half, because of what happened with the UK. So again, what I'll say is that there's not a clear path here in the United States where people are eligible. I think the general rule of thumb, at least in the ethical part, is that if you're eligible for the vaccine, you're eligible to, and you're a control subject, that you should be allowed to leave the study. You should be informed that you can leave the study and become vaccinated. And obviously there's still controlled trials being done throughout the world, because the vaccines such as the Pfizer and Moderna vaccine are not offered. But at least here in the United States, that's kind of the rule of thumb that has been used. Now, then the question is, and I think which was the crux of the question is, well, is that going to prevent us from answering important questions? And I think Dr. Quaranta, Dr. Shanghold raised the issue about how long is this vaccine going to work for? Is it going to work for 3 months, 6 months, or 1 year? So the bottom answer is yes, but there are alternatives to doing this. This is what we call these post-licensure studies, where we're looking at not everybody, unfortunately, not everybody who's going to be offered the vaccine will take the vaccine. And by following our populations, and this is certainly the CDC is ramping up doing this, following large populations of people who choose not to take the vaccine, we will still learn and hopefully answer those key questions about the duration of the vaccine, as well as the issue about spacing, because not everybody will take the vaccine exactly for weeks afterwards. So a lot of those studies, and a lot of people, including WHO, are drilling down on exactly how to run those trials in an ethical way, but also get as soon as possible this issue. Dr. Quaranta raised this issue. Well, how do you compare one vaccine to another vaccine? And there's been a lot of harmonization of protocols across the different, trials in different companies to kind of answer those issues of comparability. But we're going to have to do a lot more research, and unfortunately, the answers are not like right now when we're having to vaccinate large people. We're going to have to learn a lot more and be kind of humble about what we know and what we don't know.
Thank you. So, Senator Summers, to you, some closing thoughts, or
Absolutely.
you want to make sure everybody gets with it as they're leaving?
Absolutely. Well, first of all, thank you so much for giving us an opportunity to come and speak to you and answer some of your questions. If you did not get your question answered, because I know there was a few that we couldn't get to, please feel free to reach out to Jeff or Mary and they can forward them to us, or you can reach out to me directly. And we will try to get those answered for you so that you can feel comfortable in your decision to get this vaccine. Again, I'm just going to leave you with, all of us on the panel are extremely grateful for the great work that you all have done over the past year and continue to do with this pandemic, something that we have not seen in our country or world in over 100 years. We understand how difficult it has been. Many of us, even myself, have children, and we do understand that are in school and understand how difficult it is on them and you and all the extra things that you have to do. And I really want you to know sincerely that we prioritize you and that we want to get you the vaccine as soon as we possibly can. We do advocate for this. And again, that final decision lays with the DPH commissioner and the governor and his administration are the ones that make that final determination. So I hope that you have enjoyed tonight. I also would like to thank our panel of experts, Dr. Ko, Dr. Shangle, Dr. Quaranta. All of these folks have donated countless hours, almost every night. I see them more than I see anyone, to make sure that we are spreading the information that is correct and factual, and sort of dispelling some of the myths that are out there concerning the vaccine. And again, just thank you everyone for all that you're doing. Please persevere. We're going to be persistent to try to get you the vaccine. We are asking for patience. I know this is difficult. It is very frustrating for all of us also that we can't be able to tell you, you can get it on this date and at this location, but we are on your side and we are working on this every day. So I hope that you found this webinar informative, and I want to just tell you again, please be patient. We are going to persevere, and hopefully we'll all be looking back on this in a few months, and we can put COVID as a thing to our past. So enjoy your evening. Again, thank you so much. And thank you so much to the panelists. We truly appreciate you taking time out of your busy, busy days to be with us.
Absolutely. And thank you from the participants and my organization. Mary, I'm sure AFD Connecticut feels the same way. Thank you so much for spending time with us this evening and really answering a lot of tough questions during the night. Mary?
Thank you.
Yes, thank you very much. So, we are union people, and we believe that together we have more strength. And tonight we found out that together with you, we can learn how to make the good decisions, informed decisions. And we really do appreciate your time and your expertise. We're really happy to hear that you hear our sense of urgency. I think more than anything else, we face fear with facts, and we face the COVID with that sense of urgency. So thank you very much. We very much appreciate it.